Hello, everyone. Welcome. It's July 8th. We are fortunate to have Dr. Miller with us to address any questions and provide a short presentation on COVID-19 and some safety measures that we can do within our district. Dr. Miller, welcome, and thank you for being with us.
Well, thank you. Thank you very much for asking me to have this conversation with you. This came about because your school superintendent, Becky Walker, and I had a previous conversation. She reached out to me to help get my input, if you will, as I guess a sort of a local subject matter expert in helping her look at the policies that you're trying to develop so that you can reopen your school safely. And I want to acknowledge at the beginning that I understand that certainly parents want their kids to go back to school, teachers want students to come back to school, administration wants this, the community wants this, and at the same time, everybody also wants this to be a safe process. And what Becky and I thought was that if I could provide you with some information, because I know there's a lot of disinformation out there, maybe that could help this process, this conversation that needs to take place, in which you develop policies and procedures around how this is going to safely happen, that can be more of a rational conversation and not one that's swayed so much by fear. Because I think when we make decisions that are fear-based, those are usually not very good decisions. So anyway, I hope that that's what comes out of this. And we're going to have other opportunities in August, hopefully to speak as we get closer to the school reopening date. I am available. I also want to mention to you that my own mom was a school teacher for over 40 years. She taught in the small copper mining town in Arizona that I grew up in. And she taught third grade special education, and then at the end of her career, kindergarten. And kindergarten was her, by far, the most favorite class that she taught. And so I do have a special place in my heart for teachers. And I do understand some of the challenges that you all face trying to balance state and national guidelines, expectations of parents, school boards, etc. So these are important topics. So this is what we're going to talk about today. I'm going to spend about 30 minutes giving you a presentation. It may go a little bit longer than that. And I'm going to try to put into the presentation the questions that you asked. You provided me with 20 questions, and these were really all excellent questions. And so I'm going to try to kind of mix them into the presentation. The presentation is going to cover the following things. So we're going to talk about what is a virus, and then particularly what is SARS-2, which is the virus that causes COVID. Where did it come from? How is it transmitted? And that information is going to be very important, because then that's the scientific basis, if you will, for the discussion on how to prevent the transmission. So bear with me if we talk about some things that some of you may already know. We're going to talk about how effective is your personal protective equipment, or PPE. And then we're going to touch on testing. Most of the questions that I was asked had to do with testing. So we're going to talk about comparing both PCR testing, which is for the virus itself, with antibody testing. We're going to touch on some treatments at the end, as well as whether or not we may have a vaccine in the future. And then we'll make a few comments more specific to policy development. So with that, let's go ahead and start. The first thing that I would like to share with you is that viruses are not alive. And that may be a surprise to some people. Viruses are simply a particle, a chemical particle that has a surface, which we call a shell or a coat, and that can be made up of, sometimes it's hard and made up of protein, and sometimes it's very soft and made up of fatty material, which we call lipids. And in the case of coronavirus, it is a lipid coat. And in fact, it's made up mostly of cholesterol. And that is very important, because that plays heavily into our strategies for disinfection, as well as how to minimize transmission. So this particle, this chemical particle, has a cholesterol coat. On the surface of that coat are proteins which are designed to engage receptors on the surface of host cells. So you can think of this as a key going into a lock. And if the key is a reasonably good fit, then the lock opens and the host cell is fooled into allowing the particle into the cell. When the virus particle enters the cell, it breaks open and releases a couple of different things into the center of the cell. One is it releases its own genetic material. In this case, that genetic material happens to be RNA. It could be DNA. In the case of many viruses, it's DNA. But in this case, it's RNA, which is just a different type of genetic material. And it also releases enzymes. These enzymes take over the internal functioning of the cell. And the host cell is converted into a little micro factory. It's quite remarkable. This factory now has one purpose in life, and that is to manufacture and assemble new virus particles. So the host cell no longer is doing whatever it is that it was supposed to be doing in life, and it now becomes a micro factory for virus production. And before it dies off, it may produce thousands, if not hundreds of thousands of copies of that virus. And that's how viruses work. And it doesn't matter if it's a virus that attacks a bacteria, which we call bacteriophages, or a virus such as, say, tobacco mosaic virus that attacks a plant, or viruses that attack humans, such as HIV that causes AIDS. The basic concept here is the same. This particular virus that causes the disease, we call the disease COVID, is called SARS-2. SARS stands for Severe Acute Respiratory Syndrome. And the reason why we call it SARS-2 is because it's very closely related to the virus SARS-1, which is also a coronavirus. There are literally tens of thousands of coronaviruses in the world. The majority of them do not affect humans. About 200, I think, or maybe 400 affect humans. I think it's around 200, 250. But the vast majority of them do not affect humans. And in fact, interestingly, bats seem to have some of the greatest number of coronaviruses affecting them. And both SARS-1 and SARS-2 developed in bats probably many decades ago, maybe even 100 years ago. And it appears that they both developed about the same time, probably from a common progenitor virus, in a particular cave about 1,000 miles north of Wuhan, China. And as you probably know by now, there is a trade of eating exotic animals in the Wuhan area. It appears that this virus, however, did not come directly from bats to humans. It probably went through an intermediary mammal, which is a small cat-like creature, which is also eaten as an exotic delicacy. And so it is thought that this virus jumped from bats to this other animal, and then these animals were being bred and kept in captivity and sold in the markets. And that's probably how it then came to humans. Now, obviously, there's been a lot of discussion about, could this have been something that escaped from one of the two viral labs in the Wuhan area? Well, maybe one of these or both of these labs were studying this virus. We don't know. That's not been released by the Chinese government. However, one thing that we can say absolutely for certain is that this was not genetically engineered by people. This is not a bioweapon that was created. And we can talk at a later date about the biochemistry involved. It's a kind of a longer conversation. But the bottom line is that when humans bioengineer something, they do it by gene splicing. And it is very obvious when you look at the genetic sequence that this virus never underwent any sort of gene splicing or gene manipulation. That would be a fingerprint that would stand out like a sore thumb. So this happened through natural mutation. For whatever that's worth, it doesn't really matter, it's here now. The interesting thing about SARS-1 is that it caused a similar outbreak of illness. It's a very similar disease, which started in 2002 and kind of went around the world for about 2 years and then faded out. And that is compared with, for example, the influenza outbreak of 1918, which also went around the world for about 2 years in 3 big waves and then kind of faded out. So we don't know yet how long COVID-19 will be with us, but it's reasonable to believe that it will be with us for at least 2 years and very likely may fade out sometime thereafter. And by the way, if you're going to compare this disease, COVID-19, to influenza, the best comparison, of course, is with the Spanish flu of 1918. Not the everyday flu that we get. The 1918 outbreak of influenza was a very unique situation, just like this is a unique situation of what normally causes the common cold. Many people may be surprised to know that coronaviruses go through our community every winter. Last winter, we had 4 different strains of coronavirus go through Fort Bragg. And what did they do? They caused the common cold. But obviously this somehow, one of the mutations that this thing went through changed it, just like with SARS-1, just like with influenza and the 19 influenza. It was a unique strain that had developed because of mutations in natural evolution. And also it might surprise you to know that it appears that the 1918 flu, which we call the Spanish flu, actually probably originated in the United States. And we call it the swine flu, but actually it didn't start in pigs. It appears that it started about 4 years earlier in horses and caused the equine influenza epidemic of 1916, I believe it was. And then it jumped to chickens. It was called henfluenza, and then it jumped to humans. And I believe the thought is that it jumped to humans in Arkansas. In 1918, remember, World War I was going on, and there was a company of soldiers which were recruited from Arkansas, if I have the state right, and that's how it really kicked off. And then those soldiers, after going through training, were sent to Europe to fight in the trenches, and that's how it really started spreading throughout the world. So anyway, that's a kind of a byline there, but I think it's of interest as to how these things go around and how we inappropriately call them things like Spanish flu, which probably really started in Arkansas, and swine flu, which really only went into swine after it had gone through humans and then jumped into pigs. Anyway, moving on. So that's a little summary of what SARS-2 is, and it obviously causes this disease, which we're calling COVID-19. This disease is very similar in the way it affects our body, the way it infects our body, as the way the cold does. It gets inhaled or ingested, and it attaches to cells in our upper respiratory tract. And as I was saying earlier, is moved into those cells, which then start producing the virus. Our immune system has 2 mechanisms which are designed to fight viral infections. One is called antibody-mediated immune response, and the other is cellular-mediated immune response. We're going to talk more about the antibody part later when we talk about testing. Let's talk about the cellular-mediated immunity, because that's important. It turns out that this is the reason why we have such a severe illness or severe response to this infection. So our immune system has cells, lymphocytes, which are designed to look for cells that are infected with a virus and kill those cells. And those lymphocytes are called natural killer cells. There are many different lymphocytes in our immune system. The natural killer cells are designed to look for cells whose genetic material has been altered. And that alteration could be from cancer. So these natural killer cells are how our immune system fight cancer. They detect a cancer cell and they kill it. They destroy the cell. Or if it's a cell that's been infected by a virus, the genetic material in that cell is obviously alien. The natural killer cells kill the cell. That process of killing all these cells is an intense inflammatory reaction. And so you end up with a bunch of cells that are dying. And so that's where a sore throat comes from. When we get a cold or another infection, that is where a sore throat comes from. It's that inflammatory response of these lymphocytes killing our own cells, which have been, of course, altered. And when we cough and we bring up phlegm, for example, the discoloration of that phlegm, the yellow that we're all so familiar with in phlegm when we're sick, those are actually dead lymphocytes that are yellow, millions and billions of them in there, that give the discoloration. When we bring up phlegm that's brown, for example, that's from microscopic hemorrhage and iron that's oxidizing, rusting, and it gives the phlegm that color. Why am I mentioning these weird things? Well, I'm mentioning it because so that you have an appreciation for how the inflammatory response to a viral infection causes a lot of the symptoms of that viral infection. So with respect to COVID-19, the main problem is that the inflammatory response is so over the top intense that a lot of the damage that's done to our body is actually from the inflammatory response, the destruction of the lungs, the damage that can occur to the heart and kidneys, the clotting problems in the bloodstream that can lead to some strokes. Those are all inflammatory mediated effects. And so therein lies opportunity for treatment. And in fact, as we'll talk about later, things like hydroxychloroquine and steroids and other treatments, the most effective of which may end up being ones that are designed to actually tone down the immune system. So that's COVID-19 in a nutshell. Let's now turn our attention to how is this transmitted. Well, we really have a very good understanding of how this is transmitted. And this may be for many people the first pandemic that they've gone through. This is the second big pandemic that I've experienced in my professional career. I went through medical school in the 80s, and AIDS was really a massive worldwide pandemic at that time. And it took 4 years before we all agreed that it was caused by a virus. And it took equally a length of time before we had agreement on how it was transmitted. We didn't have a really good test until I think about 5 years into it. And we didn't have really a good treatment until I believe about 1987 with AZT. So the reason why I mention this is because we have really moved remarkably forward with this illness. We've really only had it about 6 months now, and we know so much about this illness, and we do know what causes it, how it's transmitted. So the three main ways that this thing is transmitted are, number one, the highest risk is aerosol, the second is droplet, and the third is surface contact. So let's talk quickly about each one of those. Aerosol is probably not really relevant for the community, including for you as teachers and school workers in the classroom. Aerosol is really something that is more of an issue when we have medical procedures that we're doing. Aerosol means that that virus particles are liberated into the air as single particles, which are kept aloft by air currents in a room and can remain in the room probably for about an hour. There's debate about whether it could be longer or not, but if you just follow what the CDC says, it's probably about an hour. So what are some things that would be examples of procedures that might create an aerosol? Well, when a dentist does that high frequency drill cleaning things that they do, those absolutely generate aerosols. Nebulizer treatments for asthma, for example, create aerosols. That's the whole way a nebulizer works. The medication is being aerosolized. So in healthcare settings and perhaps in school settings, we are moving away from using nebulizers for treating asthma attacks and focusing just on inhalers, which do not create an aerosol. Aerosols, as we'll talk later, are important for what type of personal protective mask we use. The main, so aerosols are the most risky, but they don't represent the most significant in terms of overall transmission. The most significant for overall transmission, and including in school settings and in hospital healthcare settings, are droplets. So droplets are small globules of spit, saliva, that are liberated into the air, and breathing produces a very small amount. Speaking, like I'm doing, produces more. Coughing produces a lot, and sneezing produces a tremendous amount of droplets. So speaking like I'm speaking might be producing maybe 100 droplets per minute or something like that, while a single cough can produce 30,000 droplets, and a sneeze can produce over 300,000 droplets in one sneeze. Droplets are heavy. They may be microscopic. Well, if you sneeze, you can see some of them flying out. But for the most part, what we're talking about are things that are pretty small and hard to see, but they're heavy. And they start dropping down towards the floor immediately. And within 2 to 4 feet, they're already well below any sort of height that somebody next to you could breathe them in. And by 6 feet, they pretty much hit the ground. Hence, the requirement of social distancing being 6 feet. Now, masks, and we'll talk in a little bit, are designed to really prevent that droplet exhalation or sneezing especially. When we think about some of the outbreaks that we've had recently in our area, I'd like to point out, for example, that while speaking normally may produce droplets, screaming and yelling produce a lot more. And so we see outbreaks at political rallies, for example. And then another is loud singing. And singing produces more droplets. And of course, we're all aware that a number of church events where there was singing have been associated with significant outbreaks. So that gives us a perspective on how this can be transmitted. So let's now talk about surfaces. So surface contact could be something person to person, such as shaking hands, where somebody has coughed or sneezed or touched their face, and then shake your hands. That's obviously a surface-to-surface transmission, and then you touch your face. But mostly what we're talking about is when those droplets from a cough or a sneeze go out and start settling on surfaces. They would settle on a desktop or a telephone or something like that, and then you come in physical contact with that, or a doorknob, I suppose, and then you touch your face. So then that brings into question, one of the first questions that you guys asked is, well, just how long can these things be viable on a surface or contagious? And that gets us back to the things that we were talking about earlier. And that is that this virus has a fatty coat. The coating or shell of this virus is primarily made up of cholesterol, and therefore it dries out very quickly. Versus if this was a virus that had a hard protein coat, it would be more resistant to drying. This also is the reason why alcohol gels are very effective, because alcohol very rapidly dissolves fatty membranes. And so alcohol very quickly disrupts the outer coat of this virus and all fatty viruses. And then very quickly the RNA is disrupted. RNA is a very unstable form of genetic material. DNA is very stable. So that's another important thing that and is part of the reason why I mentioned this earlier, is that DNA viruses tend to be much more stable in the environment, while RNA viruses tend to degrade much more quickly. So then what does that translate into? How long, in terms of minutes or hours, is it safe? Well, One of the questions you asked is, well, if we wipe our, if we wash our hands with the alcohol gel, how long does it take before it's neutralized? And I would say probably less than a minute. It's very quick. And we've been using alcohol gels in hospital settings for probably 20 years now as a way of protecting patients from transmission of all kinds of things, not just viruses. So we know that it's very quick, within minutes, certainly. And then on surfaces, if you were to wipe the surface with some sort of chemical that's designed to knock out viruses, it's pretty quick. Now you have to follow the directions that are on the surface, on the container, because some of these take longer, and the product will tell you on the container how long it has to stay on the surface. But if it's an alcohol-based one, it's usually very quick. What if you aren't? So what about surfaces where we didn't try to decontaminate the thing? What about a desktop if you didn't wipe it down? How long would, if there were a virus on that, how long would it last? Well, the answer to that is it depends on the surface. Because once again, if we think about the fact that the first step in the virus naturally being neutralized is it drying out, and then very quickly thereafter the RNA breaks down, then it depends on the surface and what kind of drying properties that surface has. So things like paper and cloth, it probably breaks down very quickly, certainly within an hour or a few hours, while harder surfaces such as plastics and metal surfaces, it can take over a day. And there have been some studies that have shown that it could be up to maybe 96 hours. However, the majority of the virus is going to be denature and deteriorate well before 96 hours. But if you do a study and you try to detect the virus, you can still detect it in some studies up to 96 hours. But that does not mean that that surface is contagious for 96 hours. You have to get a certain number of the viruses into your body. One virus or two is not going to cause the illness. It has to be hundreds of viruses, at least 100, maybe more. And that's the reason why surface contact is not the most important way that this is transmitted. If you're thinking about droplets, once again going back to droplets, and thinking about a sneeze putting out 50,000 or 100,000 or more droplets, and each droplet having tens of thousands of virus particles in each droplet, then you've got a situation where if somebody sneezes in your face, you're probably going to get it. But if you're coming in contact with surfaces, then it's much less likely to be contagious with that. So let me I have the questions that you've asked, so let me pause and look at some of the questions to make sure we've got some of these answered. So one question is, if a student comes to school with a fever, how long will it take to know if they have COVID? Well, I would say that question is probably asking, if we do a test on them, how long is it before we get a test result? So if a student were say tested right away, then it depends on the test. Most tests, the result would be back anywhere from 8 to 12 hours. However, as you may know, we're having a lot of challenging with testing nationally. And despite what the federal government and our leaders at the top may tell us, testing is not easily available. We are having a huge struggle out here in Fort Bragg to get adequate testing, both in the hospital as well as for community surveillance. So the challenge isn't really how long it takes to run the test. These tests run anywhere from about 45 minutes to 2 hours for the machine to do its thing. But actually, the fact that we don't have readily available testing, and so a lot of the turnaround is simply transporting the test to a laboratory somewhere and then waiting for them to get through their backlog and run the test. So I know that's kind of a long answer to your short question, but if we were to send it out, right now the turnaround is anywhere from 4 to 7 days, and it can be as much as 10 days. But if we do the test in-house here at the hospital, we can have an answer within about an hour. And so when we are testing people who are symptomatic, certainly patients who are symptomatic, or if, say, this student were sent to their doctor's office and the doctor was to say, well, you know, we would like to get a test, and they were to send them to our lab, from the time we do the nasal swab to when we would have an answer would be about 1 to 2 hours. And because of the fact that we're having such a challenge with getting testing, we are having to make that kind of choice. So if someone is asymptomatic and just curious because they think that they might have been exposed, then we're probably going to have to send that test out because we just don't have the test kits to be testing everybody who is concerned. But if they actually have symptoms or something like that, then we are using our own tests, which we have a limited supply of, and we can return the answer in about an hour. Moving along, how long does it take for symptoms to arise after being exposed to the virus? This is an excellent question. The answer is pretty well worked out. It's 2 to 4 days. So the incubation period is about 2 days to 4 days. And by 4 days, 80% of people will be symptomatic with the infection. We talk about 14 days simply because we want to say, what is the absolute window here? So we've extended it out to 14 days just to make sure that we get all those stragglers. If you think about the bell curve, you know, all those stragglers out here that maybe still are trying to incubate and wait until they become symptomatic. But the vast majority, 80%, will be symptomatic by 4 days. And so, and it takes a minimum of 2 days. So people will not be symptomatic within 12 hours. Interestingly, it looked like back in the 1918 flu, people could become symptomatic within 12 to 24 hours. With this, it really takes about 2 days to incubate, 2 to 4 days before people start showing symptoms. Also, I'd like to point out that people are most contagious when they have symptoms and when they are sickest. Now, yes, people can be contagious prior to symptom onset. We know that asymptomatic people can be contagious. However, they are minimally contagious. And here are the 2 reasons why. Think about the fact that the more virus you're producing, the more inflammatory reaction you're going to have, the more symptomatic you're going to be. So it's when people are very symptomatic is also the time that their body is producing the greatest amount of virus to be shed. And second is, remember, a cough or a sneeze is massively contagious. So it's when they're symptomatic with the cough or sneeze. At the same time, they're therefore producing the majority of the virus that they're ever going to produce. That is when people are the most contagious. And of course, that is where all of our strategy on prevention of transmission lies, with social distancing and face masks. We're going to get into more detail about PPE in a second. Continuing with your questions. What is the current information about how long the virus stays transmissible on surfaces, such as pencils, desks, and in the air? I think I mentioned that. And then describe a safe protocol for the exchanging of papers and books and other items. Well, we in the hospital have had to deal with this because, you know, sometimes we have patients sign pieces of paper, you know, for consent to do procedures and whatnot. And so we've asked ourselves that question. So I think that, first of all, the likelihood of it being transmitted through paper is lower than, once again, on surfaces like a plastic surface or a desk. Is it 0? No. I think that the best way to approach that would be that if you're going to have people that have to be handing in paper, and I guess we're going to do a lot of things electronically now, but if you have to hand in paper, I would say that the best way is to leave the paper out so that it has a chance to really dry out good for several hours. If you absolutely want to be completely safe, leave it out in the sun for a few hours. That's what the U.S. Postal Service has recommended in terms of mail. If people are concerned that maybe the surface of their mail is contaminated, leave it out in the sun for a few hours, and the ultraviolet radiation is very effective, both in the heat from the sun and drying out the virus, once again, very key, and ultraviolet radiation, very effective in degrading RNA. RNA is very unstable, as I've said. Moving on, which contacts of the symptomatic person should be isolated while waiting for test results? So who should be isolated if you've had contact? Well, that's a complex question. It depends on how long the exposure was, what type of exposure. Was it an aerosol, a droplet? How close was the person, and what kind of PPE was the person wearing? So for example, let's take a healthcare worker, a nurse, who's taking care of not just a symptomatic person, but a known COVID-19 person who's sick in the ICU and very, very ill, and obviously is shedding a lot of virus at that point. We've got them on a ventilator, which is something that liberates a lot of aerosol. And do we tell that nurse, because they worked one shift, now to isolate? And the answer is no. We look at what kind of exposure they had and what kind of PPE were they wearing. And during that exposure, were they wearing the appropriate PPE, which in that particular case would be the full thing. The head covering, the face shield, an N95, the gown, gloves, and booties. And did they wear it? Did they take it off in a safe way? Maybe at some point, if we can talk about how to put on and take off this stuff. Certainly for those of you who are going to be working in the special ed thing, if you're going to be wearing a gown and other types of masks and face shields, we should probably have a little session in which we talk about how to appropriately put it on and take it off, so-called donning and doffing. But anyway, as long as all that was done appropriately, then no, we don't isolate that nurse. They come back and work the next day. And this is all following the CDC and state guidelines. We have to have something to follow, and that's what we follow, is the CDC guidelines. The next question, are school-aged children more likely to be asymptomatic? Well, I don't think we really know the answer to that question. Certainly they become symptomatic. They get symptoms that are similar to a cold, but they don't get as sick. And it's a very complex answer as to why older people are the ones who are dying with this and getting very sick. If you look at who gets very sick, it's the people who are in their later part of life, certainly in their 70s and 80s. The cutoff that we use is 65, but these are the people who get very sick. By the way, the vast majority of people do not get very sick. 80% of the population who gets this either never has symptoms at all, or they have a symptoms that are similar to a cold. 20% of the population get sick and require hospitalization. The fatality rate across the board, therefore, is about 2%. It depends on what study you look at, and also what part of the world, different healthcare systems. Some areas report 1%, some areas report as high as 6%. But certainly this is not like HIV. When HIV was going out around in the 1980s and we didn't have effective treatment, the fatality rate was about 100%. Granted that it took about 8 years for people to develop AIDS, but nonetheless, it was thought to be a death sentence if you got it. This is very different. The mortality rate is about 2% in the United States. But for people who are over the age of 70, it's much higher. The fatality rate is very high. So the majority of people who are dying of this are in their 70s and 80s. Moving on then to PPE. So now that we've sort of talked about transmission and we understand about the virus, let's talk about PPE, personal protective equipment. So first of all, let's talk about masks. So the order for everybody to wear a mask in the community is not to protect you, the wearer. It is to protect everybody else from you if you are transmitting it. A cloth mask is effective in if a person sneezes and those 30,000 globulars go out, they are going to be trapped in a cloth mask. Pretty much 100% of those are going to be contained within your mask. And I know that sounds gross, but that's the reality, and that's the reason why we all should be wearing a mask. Because if we're containing it within the mask, then it's not going out to other people, and it's not going out onto surfaces. Now, I see a lot of people, and I think this is going to be important in your high school, and I think it's appropriate for students to wear a cloth mask. I don't think that the students should be wearing a medical grade mask. I think they should be wearing a cloth mask. A lot of kids are going to be wearing these fancy, gnarly looking things that have a valve on them. I see them a lot. Let me talk about that for a moment. That is not effective, okay? These face coverings should not have a one-way valve. Think about it. That one-way valve is there. Those masks are designed to prevent somebody who's working, say, in a wood shop or someplace like that where there's a lot of dust, to prevent you from inhaling that dust. And of course, if you're in a workshop, it's hot, you're getting sweaty, and the mask is getting wet from all your, the steam from your breathing. That valve is designed to have your breath go out so that the mask doesn't get wet. Well, if you sneeze or cough, it's going to go right through that valve, and you've defeated the whole purpose, or most of the purpose. I suppose some of the globules will be contained, but nonetheless, that is not effective. Once again, why are we asking everybody to wear a mask? It's to keep you, the wearer, from giving it to everybody else. And if you have a one-way valve, you're not doing that. So I think that you need to have a policy that says that these high school students are wearing these fancy, gnarly masks with a valve in them. That's probably not advisable. Now, cloth masks. Somebody asked, what about cloth masks? Should it be double fabric? And are these just as safe as medical masks? So the answer is probably double cloth is advisable. Once again, cloth masks are for the purpose of minimizing you spreading it to other people. A cloth mask does prevent you from catching it to some degree, but not as good as a medical mask, i.e. paper or surgical. There's a lot of different names for these masks. So a medical grade mask is designed to prevent the wearer from catching the virus. A cloth mask is designed to prevent the wearer from spreading the virus. If everybody in the room is wearing a cloth mask, that's extremely safe. But for a teacher who's working with a lot of students all day long, it's probably advisable to consider wearing a medical grade mask. That's what we do for healthcare workers. So in the hospital, if you're working in an office, answering the telephone or something, you wear a cloth mask. And I have this nice cloth mask that I wear. It's got Winnie the Pooh on it. My husband made it for me. However, when I go in and take care of patients, I'm wearing a paper medical grade mask. And when nurses are taking care of patients, they're wearing medical grade masks. So I think probably for the teacher, a medical grade mask is probably advisable. And then what about the N95? Now the N95 is a special mask that's designed for aerosols. It's designed to prevent the wearer from inhaling an aerosol particle. So that would be really more of a medical setting where, once again, you're doing a nebulizer or something. I know that students have asthma. I think the inhaler is safe, but if they're using a nebulizer at school, maybe they should be encouraged to instead use an inhaler. I don't know if you have that at school or not, those students. But the N95 is really, once again, to prevent single virus particles that are aerosolized floating around being inhaled. And I don't really think that's your setting. I know that you have a special education situation. I'm not sure what the terminology is, where you have students who are not going to be wearing masks because of their handicaps, or not able to wear a mask or can't tolerate it. And then I know you got kindergartners who probably aren't going to keep a mask on. I sort of jokingly say, well, that's what duct tape's for, but of course I'm just teasing. But I know that little kids are not going to keep their mask on. So in those settings, certainly those teachers should be wearing, I think, a medical grade mask. And if you're going to be within 6 feet and having to come in physical contact with those students a lot, then probably wearing gloves is enough. And then changing those gloves, removing those gloves after the physical contact, washing your hands frequently, etc. Moving on. Can COVID-19 develop resistance against bleach and hand sanitizer due to overuse? And the answer is no. And the reason for that is because those are chemical reactions. Bleach is absolutely destroying all of the proteins and the RNA or DNA that's in a virus. Very effective, completely shreds it. And that is not going to be something that a virus can develop a genetic resistance against. And the alcohol, as we talked about earlier, is disrupting the surface, that cholesterol surface very quickly disrupts it, and then the thing dries out right away. So those are, and it's also even effective against protein-coded viruses as well. So that's not going to be a problem. Resistance develops as a genetic mutation to things like antibiotics and antiviral drugs and stuff like that. And then, yes, those types of resistance can develop. It's kind of a long conversation as to how that works, but maybe someday we can have another talk about that if you're interested. Let's move on then to testing. A lot of questions were about testing. So there are 2 types of testing, and I am kind of mindful of the time. We're about 50 minutes into this, and this was scheduled to be 90 minutes so that you have plenty of time for additional questions. But I am trying to intercalate your questions into the presentation. So let's talk about testing. There are 2 types of testing, broadly speaking. One is PCR and the other is antibody. PCR stands for polymerase chain reaction. And without getting too technical, but I think it's of interest, is how does the PCR test work? So what PCR does is it amplifies the genetic material in the virus, or whatever you're looking for. So what amplification means is it is a way of using molecular biology to reproduce millions and millions of copies of that genetic material. So we think about it, for example, in crime scene analysis. So you want to see if a murder suspect's genetic material is present at the crime scene. But there might be just a single hair or something that has a few copies of their own genetic material on it. There'd be no way that you could detect a single copy or a couple of copies of somebody's genetic material. So what you do is through PCR, polymerase chain reaction, you make multiple copies of this genetic material, literally amplifying it from just a single copy to maybe hundreds of millions of copies in the test tube. Now we have a target that we can detect, and that's how PCR works. It's an amazing, powerful technique, and we use it in research and we use it in medicine, and it is the basis of a lot of our tests, not just for COVID-19. And we can talk, and that's the reason why it's a very, very good test. It is sensitive at, most of the tests are sensitive at detecting the virus at about 99.3%. And that means that there's a very low false negative rate. And they're also very specific, meaning that you don't get a lot of false positives. So they're really excellent tests. The main problems can be with the sample collection. If you don't get a good sample, then you may not get enough material to amplify. If the sample is not processed correctly, then you may get false negatives. And you probably have heard that one of the tests, the Abbott ID Now test, which is readily available, and we use it if you use it in asymptomatic patients or people, then you can have up to about 17% false negatives, and that's not good. But if you do the test in the right setting for a symptomatic patient, remember, symptomatic means high viral load, asymptomatic means low viral load. Now this is a unique problem to the Abbott ID Now test, and that's the one that everybody keeps talking about. Is there a 20% false negative? But the other tests are actually very good, and you don't have that high a false negative rate. Once again, if you're interested at a later date, we can have a great discussion about why that's different. But these tests, by and large, are exquisitely sensitive, very reliable, very good. You need to have about 48 hours, though, from the time that the person is exposed till they have incubated enough to detect it. So if, for example, you had a student in your classroom who had symptoms and went home and was tested, and you wanted to be tested later that afternoon, that would be a pretty worthless test. You need to have incubated the virus and then have enough virus for us to detect it. And that's the reason why I think it's important to understand that testing is not part of protecting. A testing strategy is very useful when we're talking about protecting the community, identifying people to prevent spread throughout the community. But for an individual who's like, oh my God, I want to know if I've been exposed or not, it's not as helpful. And that's why a lot of times we just tell people to self-isolate for 14 days if possible. Anyway, that's the PCR test. And there's a bunch of different ones that are out there. The antibody test is an interesting question, and once again, I'm mindful of the time. It's kind of a long discussion, but let me say a few things. So first of all, as I said earlier, coronaviruses go through our community every year. This year we had 4 coronaviruses go through. They call this the common cold. All these coronaviruses are very, very similar. This one particular one, SARS-2, has some unique traits that obviously make it extremely deadly. But our antibody reaction to these viruses is pretty much the same, and therefore there's a lot of cross-reactivity. So if you have an antibody against a coronavirus and you get a positive test, that does not mean that you necessarily had COVID-19/SARS-2. It could have been a cross-reactivity. And the majority of antibody tests that are out there right now, in my opinion, are not worth a whole lot because of the problems with cross-reactivity. And that's the reason why we've decided at our hospital not to offer antibody testing. Some people are frustrated by that. The other reason why we're not offering antibody testing is because these antibodies do not necessarily mean that you have any sort of immunity whatsoever. Let's think about HIV, for example. The majority of tests are antibody tests. People do develop antibodies against HIV. We know that. But these antibodies are not, they do not give immunity. People, once they become infected with HIV, have it for life, for the most part. There are a few people out there who seem to have completely cleared the virus, but the vast majority of people have the virus for the rest of their life, and yet they have antibodies. These antibodies are obviously not effective in causing immunity. And that's also the reason why 40 years into this, we do not have an effective vaccine against HIV. We have vaccines that do cause antibody production against HIV, but none of those antibodies are protective. None of those antibodies cause immunity. And if we compare, once again, the common cold, coronaviruses, and the common cold with SARS-2, what happens with the common cold? Well, those antibodies that do give us immunity only give us immunity for about 3 weeks, and then they fade. So I'm kind of jumping ahead a bit, but it's unclear whether we will ever have an effective vaccine against this, because it's unclear at this time whether or not any of these antibodies are effective against the virus. Harkening back to what I said at the very beginning, we have two different types of immune systems. We have antibody-based and cellular-based immune system. And the virus, the immune system that's most used in this particular type of viral attack is the cellular branch of the immune system. So whether or not antibodies will ever play a role in any sort of immunity is unclear. And so that's the reason why we should be careful about this antibody testing. So I'm hearing a lot of people saying, oh, we heard that somebody had an antibody test, this means that, and it turned positive, but they were living in, the Antarctic. So this means that, COVID-19 must have been around for a long, long time before we really knew it. Well, the answer is no. It's because it's of cross-reactivity. And also, I want to get an antibody test because I want to know if I'm immune. No, because we don't know if any of these antibodies will ever be immune. So I don't want to belabor the point, but that's antibody testing and the problems with it. So let's see, testing. So we've got a few more testing questions. How important is it checking people's temperature when we know that asymptomatic people can spread the virus? Well, that testing, I put that under testing, it's kind of screening. So I believe your policy is going to be that everybody gets screened with a temperature check and questions about whether they have symptoms, which would of course be fever, cough, sore throat, shortness of breath.
Hi, Dr. Miller. I'm going to interrupt you really quickly because the board will be approving those policies. And what we're looking at right now is having the families doing the screening prior to coming into school.
Okay. Well, I don't want to try to say what your policies are going to be about or direct your policies. So thank you for that clarification. But those are the screening things that we use in the hospital. We don't use the sore throat one for a variety of reasons. We can get into that. But the questions that we ask are, do you have a fever, a cough, or shortness of breath? And then we take the person's temperature. And we do that for all employees, 100% of employees, 100% of people coming in to visit patients, etc. So how effective is that? Well, it's not a complete test. It's a screening, okay? And we know that when somebody has a fever, they don't have that fever continually. Fevers come and go with all illnesses. But it is part of the screening along with the questions that we ask. The idea there is to minimize the number of people who might come in and be contagious. And also keep in mind that, yes, asymptomatic people can be contagious, but the majority of spread is going to be from people who have symptoms. And so what we're trying to do with these strategies is we're trying to prevent the majority of spread. There is no way we're ever going to be able to do this 100% unless basically you isolate yourself in your bathroom for the next 2 years and you never come out. That's the only thing that's absolutely 100%. So what we're trying to do is we're still trying to have an economy. We're still trying to have education for kids and all these things, understanding that, for example, with shelter in place, as we roll back shelter in place, we will have contagion. We know that. It's unavoidable. But what we're trying to do is minimize the spread. But we know we will have cases as we should roll back shelter in place. And we know that some of those people will get very sick and will die. And that's the truth. That's the unavoidable truth of this illness. But we're trying to do it in a thoughtful way so that with respect to shelter in place, we can still have some sort of economy after all of this is done. Let's continue with the questions. What criteria will be used to see if somebody qualifies for a test? Well, there are two testing strategies. The first is for people, it would be a medical testing strategy, and that's primarily based on what symptoms they have. And I've already mentioned the symptoms. And then the other testing strategy would be for community surveillance, and those people would not have symptoms. So that's the qualification. What do you anticipate about turnaround tests in August? Well, if you'd asked me this question 2 weeks ago, I would have said probably very quick. But now testing is becoming a challenge again because, you know, Florida and Texas and Arizona and Southern California are all having this massive outbreak. And all of a sudden, we're back to where we were about 2 months ago in availability of testing. It's very frustrating. I thought we'd finally gotten this thing whipped and that we were going to have enough tests. And now all of a sudden, we've got another national shortage of testing equipment, of kits and of the transport medium. So, but I think probably if a person is symptomatic, we would test them here in the hospital, and the turnaround would be hours to maybe 12 to 24 hours at the most, because we got to handle the sample. But if a patient or community surveillance test, it'll probably be 7 to 10 days in August. Let's move on. Where can I get tested for COVID antibodies? As I've said, we've decided that we're not offering that test at this time. You can, I believe that there are places over in Santa Rosa that are offering antibody testing. I would not recommend it at this time. However, there is what is probably going to be an extremely reliable antibody test on the horizon in the next few weeks. And it looks like it's going to be very specific just for SARS-2, which is what we want, because we don't want a lot of confusion with false positives, cross-reactivity. And that's probably going to be out and available in the next few weeks, and we are definitely going to offer that when it becomes available. There may be a national shortage of that too. I would expect it. So we would like to offer it as soon as we can. But as I said, whether or not that test will tell you whether you're immune or not, it'll be probably at least a year before we have enough data on the antibodies that this thing is producing to know whether any of them lend immunity. And then the last question is, does having a negative COVID test give a false sense of safety to a person or others who were recently tested and could be then leaving the testing site or the hospital and on their way home contract the virus? So yes, so the COVID test is only that you didn't have it in your nose at that time. It doesn't tell you that you could be incubating it, as I was saying earlier, 24 to 48 hours before you've got enough virus for us to detect with the swab up your nose. So, so it just means that at that moment when we swabbed that person, they didn't have virus, they weren't shedding virus in their nasopharynx, but it doesn't mean that they aren't incubating it. And it also doesn't mean that on the drive home, they celebrate their negativity by stopping by a bar and yucking it up with their buddies and then catching it. So obviously, and people, I think most people know that as soon as you leave the testing center, you could obviously then contract it. And then, but once again, it's a very good test. So if you're talking about somebody where the exposure was certainly 48 hours earlier, I would say 99.3% likely that if it's there, it will be detected. Okay, so let's talk quickly, moving on, about treatment. One person asked about hydroxychloroquine. Will hospitals be allowed to use hydroxychloroquine since it has been proven effective if given early enough? Well, so about hydroxychloroquine, also known as Plaquenil, it was originally, of course, developed as an anti-malarial drug, but we use it as an immune suppressant. We use it to treat lupus and rheumatoid arthritis, to suppress the immune system in those patients, because in those illnesses, the immune system is attacking their own body, and that's the problem. That's what's called an autoimmune disorder. And so Plaquenil is used, as is prednisone and steroids, to suppress the immune system. Whether or not Plaquenil will end up being any sort of mainstay treatment is very unclear. The data, some studies show a modest improvement. I would not agree that it's been proven effective. I think that the that it probably is not going to end up being anything that we're going to use on any regular basis. Some of the studies suggest that there may be some modest benefit, while others suggest that there's no benefit whatsoever. And some studies suggest that it may be harmful. When you have a situation where you have such studies that are equivocal and nothing's really jumping out, my opinion is it's probably not that valuable. If it was really a valuable treatment, it would be clear. It would really jump out. The studies would show a clear benefit. I'm not personally, as a doctor, interested in having to treat 1,000 people to get one person a benefit. And that's how we look at these things. The number to treat to benefit. And if you have to treat, like I said, 1,000 people for one person to get a benefit, which some of these drugs are, I'm not interested in that. Now, some treatment, for example, with steroids, probably will become a mainstay. Decadron and prednisone. Some of these are, and once again, they're immune suppressants. They specifically attack your own lymphocytes. And that's how they work. And remember, as we talked earlier, it's the lymphocyte reaction, those natural killer cells, that are causing such destruction in our bodies by sort of making an over-the-top overreaction, if you will. And then we've also already talked about vaccinations. I'm going to end here, and then we're going to have time for hopefully a few questions from you. There were a few policy questions that were given. The first one, if a student or staff member tests positive for COVID, should the entire district shut down for 14 days, or how long should a classroom be closed? So that's an answer that I think your school district is working on developing a policy around. But I think also it depends on the situation. I think it's going to have to be a case-by-case situation, and I think the county health department is going to have to be involved in helping your school administration make that decision on when it's safe. For example, if a student comes down with COVID, and let's say the whole family comes down with it, and we say, oh my goodness, should we close the school for 14 days? And then we do some contact tracing and study, and we discover that, oh, well, wait a minute, the last time the student was at school was 2 weeks ago. Well, I mean, I'm giving that as an example of one extreme to say, well, no, okay, the student came down with it, but they weren't in school for 2 weeks. You don't have to close anything down. Or the other extreme might be, yeah, they were in school that morning and they weren't wearing their mask and they were coughing and sneezing all over everybody. Well, that would be a different scenario. So it would have to be a case-by-case basis. So I don't think I can answer that. I think it would have to be based on your school policy at that time and on the health department. I do know that the CDC, while they put out a lot of stuff that's been helpful in the healthcare industry for making these kinds of decisions, because we have all this worked out on the healthcare side, it's a little less clear and there's far less directive for things like schools. However, I'm willing to participate in any conversation that might help with the policy development. Moving on, another question. Our health orders discuss maintaining stable groups of 12, but in our current reopening plans, teachers will have upwards of 100 contacts per week. Please comment on the risk to students and staff in a situation and explain how this would be in line with current health orders. And a related question, why is there a time period of 4 weeks when working with stable groups for specific members? So I think what both of these questions are talking about is the idea of having a stable group. In some countries, we're referring to those as social bubbles. I kind of like the social bubble reference better than stable group. But basically what we're talking about here is we're talking about how do you go through life and what kinds of personal protective equipment, PPE, do you need to be wearing? Well, if you're at home and you're with your spouse and your kids and your dog and the cat, well, you're not going to be wearing PPE. You're not going to be wearing a mask, etc. And so how do we define that group? Well, that's what we're calling a social bubble or a stable group. And then, of course, maybe you add the grandparents to that. Maybe you add, maybe you have a very, very dear friend who comes to dinner every night, and you're going to include that person in your immediate social bubble or stable group. And the idea here is, all right, people, we understand we're humans. We need to have interaction with other people. If we could just somehow allow that interaction with other people to be limited to just a small group of people, then we won't have a lot of transmission. But if you're going to have to interact with more people or people who are ill, then you're going to have to wear some sort of appropriate PPE. And so that's where, so I don't think that stable groups apply to the teacher-student relationship. That is not a stable group. That's not your social bubble. Your social bubble or your stable group is where you can be without your mask. That is a group where you need to be wearing PPE. And that, of course, means students should be wearing a cloth mask and teachers should be wearing a face covering as well. I know you haven't decided your policy, but probably it'll end up being, I would guess, a medical grade mask. So that's my presentation. I hope that you found that helpful. And I would like to open this up to any chat questions in the time remaining.
Thank you, Dr. Miller. So we do have a few questions from our group. First off, can aerosols build up in an unvented, let me start again. Can aerosols build up from speaking in an unvented classroom over time?
So speaking does not create the aerosols that we're talking about. They primarily create droplets. So the answer would be no. And so when we are in the medical situation, we're not doing anything special for a room with respect to droplets floating in the air. So I would say that the main concern here with speaking is droplets, not aerosol. And so I would say no, that they would not be building up because they would not be being formed in any sort of meaningful number or way.
Great, thank you. You've talked about medical grade masks for our teaching staff, and you and I have had that conversation about which mask. Could you be specific when you say medical grade mask? Because it's not N95, is it another number, so that we know what we're ordering?
Yes, so there are many different versions of the medical grade mask. Some are called isolation masks, some are surgical masks, and the nuances are not important for you. They're all the same as far as their effect. The nuances for us are that, you know, the surgical mask is the one that has the strings that tie in the back, and it's easier for the surgeon to have their hood on because their hood in surgery is covering their ears, so they can't have the little ear mask. So that's the difference between a surgical mask and, say, a isolation mask, because in an isolation mask, you want people to come out of the isolation room and not be futzing around with trying to untie a knot. You want them to be able to take the mask off and discard it. So that's the difference, is the way the mask is constructed. But the paper part is pretty much the same. So any sort of medical mask would be appropriate.
Okay, and are those single use?
So the reason why I sigh and take a breath here is because it has to do with availability of the masks. Now, they're all designed to be single use. However, we have a worldwide shortage, as you know, and that is fluxing as hotspots develop here and there. So what we're doing in the hospital is we're having people who are working with patients. They are given one paper mask at the beginning of the shift. They wear it all day long, and at the end of the shift, they discard it. And so it's one day use. If it becomes kind of, gross because of, whatever, you sneeze into it, or it becomes dirty or somewhat, then obviously they change their mask. So I would say probably the best is to have everyone using one mask during the day, unless it becomes a problem with that mask or the band breaks or whatever, and then obviously you replace it.
Okay, and Dr. Miller, could you help clarify older, younger students? Because if let's say I'm a teacher in a class with 15 kids and I'm wearing a cloth mask and all my kids are wearing a cloth mask, do you still see a need for the medical grade mask for the teacher if we're maintaining social distance?
I don't think that there's a need. I think that the cloth mask, if everybody in the room is wearing a cloth mask, that's a very effective way of preventing the transmission. But if you wanted to add yet an additional level of safety for the teacher, then you would go with a medical grade mask. But we're talking about even if the teacher is wearing a cloth mask and the students are all wearing cloth masks, the chance of transmission, even by the end of the day, would be well less than 1%. Once again, a student who's sitting there coughing and sneezing behind their mask is going to be asked to leave the room, I would imagine. So this is just to prevent the possibility of asymptomatic people transmitting it in a room. If they're symptomatic, they shouldn't be in that room. A symptomatic scenario is a different scenario. And that absolutely requires a medical grade mask, but that should not be the scenario that you guys have.
Correct. Thank you. Another question. Would the presence of one symptom warrant a medical test, or are multiple symptoms required? And let me give you a little background, Dr. Miller. One of the things that we anticipate is that if a student or a staff member is tested positive for COVID, you're going to have, I believe, that we're going to have a lot of people going to our clinic and our hospital really demanding a test because there is fear with this. So at what point does the hospital, clinic, our medical providers say, yes, you get tested, no, you don't?
So I think there's two questions embedded in that. And the first, I think, is about screening, and then the second is what you just said. So yes, my experience so far is that, so let me back up and say this. As we continue to roll back shelter in place, we will have patients, we will have people in our community. I use patients because I'm so used to that terminology, but we will have people in our community who will get COVID-19. And we absolutely will have it. And you absolutely are going to, at some point, have a student who comes down with it. You probably will have a teacher at some point who comes down with it. These are realities. We're going to have nurses. We're going to have doctors. As this thing continues over the next couple of years, there will be periodically people having it. So that's absolutely going to happen. Whether they got it at work or they got it at home is going to be part of how you deal with this and trying to figure that out. Now, I can tell you from my experience that the first time a coworker comes down with it, everyone freaks out and everybody wants to be tested immediately. That's been my experience so far. The second time a coworker comes down with it, hardly anybody wants to get tested. It's sort of, you're over it. Okay, I know, but I was wearing my PPE. She was wearing her PPE. Now I kind of understand that, you know, because, for example, we've had, as you know, a couple of nurses who have tested positive, one of whom turned out to be a false positive, fortunately, and the other might have been a false positive or it might have been a true positive. It's hard to say. But we tested hundreds of people and every single person was negative. So anyway, the point is that people do react with a sense of fear, and I understand that, and I'm not trying to minimize that or belittle it. But from a medical perspective, we are not going to be able to handle a stampede of people wanting to be tested who are asymptomatic just because they're afraid that they might have been exposed. Our response to that is going to be, look, are you symptomatic? If you're asymptomatic and you think that you were exposed, what was your exposure? What was your PPE that you were wearing at the time? You know, the fact that you walked through the hallway and the student who was infected walked past you, that's not an exposure. An exposure would be, well, I was in the classroom and I didn't have my mask on and the student didn't have their mask on. We're sorry, but we decided to eat lunch together or something. Or actually, that's a good example. Maybe two teachers sitting in the teacher's lounge eating, and you got to take your mask off, and then one of the teachers comes down with it. So, all right, that's the way we look at what your exposure is. What was your exposure? And then are we going to say, well, we're going to test you, or are we going to say you're just going to have to go home and wait for 14 days? Once again, it gets into the nuances of the availability of the test, whether we're still having a national shortage. If we have to send out the test, which is what I said earlier, we do send outs for these things if you're asymptomatic. Well, if the turnaround is 7 to 10 days, then what's the point? If you're going to have to self-isolate for 14 days. So anyway, these are the kinds of nuances that come into that conversation. In the end, the final analysis is that it's going to be up to that person and their doctor. They're going to work through these nuances. And what we've tried to do is, if a person really, really wants the test, we try to give it to them. We're not trying to be, I don't want to be a gatekeeper of tests. I didn't go to medical school for that. It's not, we're not trying to hoard these things or say you can't have it. And anyway, I hope that's kind of an answer to that question. And then the first piece of your question, which is how many symptoms does somebody have to have? I think that's really more of a screening question. So I would say anyone who has any symptom is screening positive. So that's the student who comes in and says, well, I had a sore throat yesterday, or whatever symptoms you choose to go with, or they have a fever. They screen positive, and then you have to have a policy on how to handle that. What does that mean? Does that mean that they can't come to school? Does it mean they have to go to their doctor and get a pass to come back to school? What does it mean? And that's what your policy is going to have to work out. Next question.
Thank you. We have a severely handicapped population, and our special ed teachers are asking questions like face shields, are they effective? And our teachers in younger grades are considering face shields, because when you're teaching reading, you have a lot going on with speech in your mouth and wanting our kiddos to see our faces. How effective are face shields?
So face shields are primarily what we call eye protection. So the mask is covering obviously your nose and your mouth. And by the way, this is not the way to wear a mask. I see that a lot. That is not the way to wear a mask. And also, by the way to touch your mask is not, I see this a lot too. I see a lot of, people are futzing with the front of their mask all the time. Well, and this mask was just washed, so I know it's not contaminated. But if your mask is contaminated, that front part is the part you should not be touching. So you take your mask off from the side and you don't touch the front of it, okay? You don't pull your mask down like this so that you can drink your coffee. Once again, if your mask is contaminated and now you're swizzling coffee, you can see how that's not effective. So anyway, I know I'm digressing, but if the mask covers the nose and the mouth, and then you need eye protection if you're in an environment where there's going to be a lot of droplets or aerosols being produced, because as we probably all know, there's a duct that goes from the corner of your eye down into your nose called the tear duct. Your eyes are constantly producing tears, and they're constantly being sucked into your nose and you're swallowing it. And that's how your eyes stay moist and clean. So if there are droplets in the air and there's a huge number of them and they're getting in your eye, then you could become contaminated. So eye covering is on the same order as an N95. So I would think that if a person's in a situation where they need an N95, they also need an eye covering, eye protection. If it's not an N95 level type exposure, then we don't use eye protection in the hospital. So I guess it depends, if you're in a situation where you have special need children that are not wearing a mask and they're coughing and whatever they're doing, expectorating all over the place, and you're having to be in there cleaning their face, because I know how some of these young people the terrible problems they have with advanced cerebral palsy or something like that. They're moving all over the place. They're expectorating everywhere. They can't help it, of course. So, maybe in that scenario, eye covering would be appropriate. If somebody's reading, if they're in a reading group and they pull their mask down to read, I don't think eye covering is going to do anything. It's the mask that's going to do something. And if you're taking your mask off, then you've already lost your main protection.
So face shields should not be a replacement for a mask, is what I'm
Face shields
hearing.
are not a replacement for a mask. A face shield is open at the bottom. You have to wear a mask with the face shield. I see that sometimes now outside. People are wearing a face shield and no mask. Nope. That don't cut it.
Okay, thank you.
Protect your eye from stuff splattering in your eye.
Okay, so for our severely handicapped teachers, we've purchased gowns and gloves and face shields to go with their mask. Is that appropriate for kiddos who are not going to be masked?
Once again, if they're all over the place and expectorating, I think the expectoration piece is important, and you're having to be there close to them because they're constantly needing your physical touching. I think that would be reasonable. They're going to have a mask on. That mask, I think, would be a medical grade mask, not an N95, because those kids are not generating aerosols, they're generating droplets.
Okay, so the school district, we purchased balaclavas, or also called buffs, also called gaiters. They're the little things that go around your neck and then they come up over your nose and mouth. And we did that so that it could be around the student's neck and not turn into a slingshot. Are those effective face coverings?
I don't know what that is. I'm not really sure what that is. Is that thing that looks kind of like a ski thing that, it looks like a sock? Is that what that is?
Kind of. It looks like a scarf maybe, and then it goes around the neck, but kind of like my scarf, and then it comes up.
Well, I can't see your scarf, but I don't know. But basically, face covering is any cloth that covers the nose and mouth is effective at, once again, stopping any droplets that come out. And that could be your Western bandana. People are using those. I think that the best is some sort of cloth mask like this. Some of these stocking things, they're constantly falling off or whatever, but I'd have to see it to know.
Okay, and then one other question we have is, how often should we be laundering our cloth masks?
So the CDC recommends laundering them daily. So, or setting them out in the sun. So what I do is I have I have about 5 of these. They don't all have Winnie the Pooh on them. And at the end of the day, I leave it out in the sun. The air dries it, the sunlight, and I take another one the next day. And so they're out there rotating. And so that's one way to do it. I have a couple of them, leave one out during the day and wear the next one while the first one is airing out and sunbathing.
Okay, another question. We serve breakfast in the classroom. So clearly to eat, the mask has to come off your face. If kids are socially distanced, if we have a student desk 6 feet apart, and how safe is that with kids eating maybe 10, 15 minutes of everybody being unmasked and eating food?
That's a tough question. I actually don't know the answer to that. I think that, obviously, in our efforts to roll back on shelter in place, the health department and the state have put out criteria around restaurants, which are very similar situation. And so in that scenario, people are without masks and they have distancing requirements in between the booths or tables. And so obviously, whoever developed in the state health department who developed those criteria felt that those were safe. So I guess I would recommend that you look at those recommendations and go with that.
Would it be better for us in our classrooms when it's time for breakfast? And again, we're talking about 10 or 15 minutes of a milk or a juice, some kind of a breakfast bar, some kind of a fruit. Would it be better if we rolled that in with like only 5 kids at a time or 3 kids at a time so that not everybody is unmasked? Would that be a safer way to go if we maintain social distancing?
Well, sure. The more that you can spread them out, and the less other numbers of other people in the room at the time, the better. So when you talk about restaurants, for example, you see that they also often say that they can only be at 50% capacity or 75% capacity. And that's exactly what they're getting at. They're trying to make the number of people actually in the restaurant who don't have a mask on as low as possible, and yet allow the restaurant to still have enough people to be able to financially be open. So yes, I would say that 5 versus 15 is a better number in terms of safety.
Okay. There's also a question about temperature taking. We've purchased a wireless touchless thermometer for every classroom in Fort Bragg Unified that will be assigned to each classroom. And we've had some people say, Becky, me taking a kid's temperature, I'm not going to be 6 feet away from them because I've got to kind of zap their forehead. How safe is it to take a temperature if both people are masked? Is there a better way to do it than not? What are your recommendations?
So, first of all, the temperature, the thing that with the temperature is a screening. Let me rephrase this answer. So the 6-foot distance is something that you're from time to time going to be closer than 6 feet. I mean, let's face it, even when we're in the grocery store, we never, we pass people in the hall, etc. So when people come in and to our hospital and they come through the screening station, we also use that infrared gun, and people do it at arm's length, and you're about 6 inches away from the person's forehead, and you just point it at their forehead and pull the trigger, and it only takes a few seconds and it gives the number. But you're doing it at arm's length. So yes, you are within 6 feet, you're at about 4 feet. But both people are wearing a mask at that time. And once again, any sort of droplets are going to be minimized. And that's how it's done. Is there some smaller chance, is there some small risk associated with that versus if you somehow did it when you were further apart? Yes, I suppose so. I guess you could try to have the student do it themselves, but then you got to clean the gun every time. That's a bother and not safe. We're all just trying to get through this.
I guess the big question is what's the risk of taking someone's temperature? Is that a high risk situation of you contracting COVID if the person does have a fever and is symptomatic? No, and you're both masked.
I would say that is very low risk, because once again, you've got people who are both people are wearing a mask. You might have that person certainly wearing a medical grade mask at that point. That's what we do for our screeners. They're wearing medical grade masks and at our screening stations. And I would think it's a very low risk if both people are wearing a mask. And you've already asked, the first thing we do is we ask, do you have any symptoms? And we ask the symptoms specifically. And if they say yes, then they don't get any closer. They've already screened positive, not tested positive. They've screened positive, and then they're handled in a different way. So that, I think, is a way to mitigate the spread. What we're trying to do here with all of these policies is we're trying to mitigate or minimize the possibility of any sort of spread. But the only way to be absolutely 100% certain is to not have any contact with anyone else, period. And obviously, that's what we're trying to get around.
We had another question about face shields. if you had a face shield over you and you used your duct tape to put some cloth around the bottom of the face shield and then tuck it into your shirt, is that effective?
Yes, I think that would, that's called a papper. Basically, that's a different kind of, that's a homemade papper. And I can't remember what PAPR stands for, personal air respiration system or something or other. But anyway, that's getting into basically your spacesuit kind of thing. And we do use those in some settings where you actually have a hood that completely goes over the face with a face shield, and it comes down around the neck. And so basically what you're doing is you're creating a homemade papper, and that's effective, yes.
Okay, great. And then there's more questions around eating and masking. And I just want to make sure that we clarify the social distancing. Let's pretend you and I are in a room and I have COVID and I'm displaying symptoms and I'm unmasked. And you are 6 feet away from me. And what is the likelihood, if we maintain the 6 feet of social distancing, what's the likelihood of you contracting COVID in that situation?
Okay, that's an excellent question. And we actually know the answer to that pretty well. So when this started to spread, when COVID started to spread, there was I believe off the top of my head, I can't remember exactly where, but I believe there were 3 hospitals in Singapore where they were taking care of COVID-19 patients. In retrospect, we know that those were COVID patients, but at the time, they didn't know that that's what they were dealing with, nor did they know that they needed to be wearing face masks and all of this PPE. So, so nurses and other healthcare workers were taking care of patients who were symptomatic. So these are people with full-blown COVID, very sick, high viral load, coughing. And the question was, in the studies that have been done, and there have been several looking at this cohort of nurses, what was the contagious risk? They did not have masks on. The patient did not have a mask on. So it turns out that you have to be, those nurses, and they were within 6 feet, they were touching the patient. So not just droplet and aerosol, but also surface. You had to be in the room next to the patient for 15 to 30 minutes to get contagion, to get spread, and the risk of contagion was 30%. So that means that if you went into the room and you were in the room next to the patient for 5 minutes and then you left, you probably did not get it. Statistically, it was unlikely that you would get it. If you were in the room with 2 other nurses and you were there for 30 minutes, one of you would get it, 30%. So that kind of puts it in perspective. So this is definitely contagious, but it's not an, oh my God, contagious. It's like I said, I've said it before. People often ask me, well, what if I passed somebody on the trails around Fort Bragg and they were on a bicycle and they didn't have a mask on? No. Somebody whizzing past you on a bike? No. Passing somebody in a hallway? No. Being in a small room, remember, hospital rooms are probably smaller than classrooms. Being in a hospital room for 15 minutes within 6 feet of a patient with known COVID, 30% chance. That helps. I think it helps put in perspective.
So if we maintain our masking, we are reducing the likelihood of us contracting COVID, even if we have an active COVID case in our classrooms. That's what I'm hearing.
Correct. And that's what we do in hospitals. We take care of COVID patients and we wear masks. Now, if we were taking care of an active COVID patient, we would be wearing an N95. It's true. But that's in a medical setting where you have very sick people. But when we're taking care of somebody who is sick for another reason, we're wearing a medical grade mask, just in case they are asymptomatic carriers. And I think that that's the scenario that you're looking at. You're not looking at, you should not be having somebody sick with a temperature of 104, coughing all over the place and saying they can't breathe. You should not, obviously you're not going to have that kid in your class. And that's the person where you got to be wearing the full outfit. You're going to have the kid who's like I said, the asymptomatic patient who were worried, could this be an asymptomatic patient? And in the hospital, that nurse is taking care of that person 8 hours a day, sometimes 12 hours, and they're getting up close and personal. That patient may be somebody who needs dressing changes, or maybe they're unable to get up out of bed and they're defecating in the bed and the nurse is cleaning them up. They're getting up close and personal with those patients for 8 to 12 hours. That would be a patient who does not have symptoms, who we think therefore does not have COVID. What is that nurse wearing? They're wearing a medical grade mask.
Okay, so for us in Fort Bragg Unified, we are going to hold a firm line that if any student or any staff member has symptoms, cold or flu-like symptoms, we are going to require them to stay home and not be in our classrooms. If we do that and accompany it with a strict masking regulation, what is our likelihood of spreading COVID in our schools?
Way less than 1%, and probably less than 0.1%. Once again, just putting it all together, not to belabor it hopefully, but putting it together. Asymptomatic has the lowest viral load. So you've already, right there, just by your screening, you've already reduced the chance of spread. Then if that asymptomatic person, the student, is wearing a face covering, if they happen to sneeze or they happen to cough, you've got it contained. So you've done a lot of protection there. You've got the 6-foot distancing. You may have other things that you're doing for surfaces, I don't know. And then you've got the teacher who's going to be wearing a face covering of some sort as well. And who, so I believe that the chance of spread is certainly less than 1%, maybe even far less than 0.1%. Is it absolutely zero? I don't think I could say that. But it's the best you're going to get, and I think it's really good.
So just to recap, and then we have one more question, we'll close out for the day. I know that there's concerns with our kids eating in class, and I'll bring up a different question again. If a teacher is wearing a medical grade mask and the kids are unmasked while they're eating, would you say that's more protective for the teacher? So that's one question. And then the next question is, if I'm a teacher and I have my kids rotating the eating so that we're 6 feet apart, is that more effective? Because I know that we have teachers concerned about kids taking their masks off to eat. So what would your recommendation be? Medical grade masks, social distancing, rotate the kids in eating so it's fewer people unmasked? Give us your thoughts.
So what I would do is an analogous to what we do. Once again, when I say what we do in the hospital, this is based on what the CDC recommends. So we're very strict about following the CDC guidelines. And we try not to add anything additional to it or take anything away from it, because I figure that a team of people far smarter than me, with a lot more resources than I have spent a lot of hours cogitating over this at the CDC, and they put forward these guidelines for healthcare workers. And so there's an analogous situation in healthcare where you would have patients in their room eating, right? People eat, and some of those patients have to be fed, right? So you're within 6 feet and you're helping that patient with a stroke or something eat. And so that's an analogous situation where you have an asymptomatic person who we think probably doesn't have it, but we're still trying to be protective. So what I need to do is I need to go back and look at that exact scenario in the CDC guidelines. I think that the recommendation is eye protection and a medical grade mask and gloves. Once again, that would be a person who's feeding the patient. I don't know the answer exactly to that, but I will get back to you with that answer.
Okay, thank you. 2 more questions. So what about reports that there is a more contagious strain beginning to circulate?
I'm not aware of that. Maybe there is something like that. This thing is going to, mutate, but I think that probably the mutations are not going to be in terms of how contagious it is, because this is highly contagious. This is one of the most contagious viruses we've got, and I don't see how it would become more contagious. But I think that if there are further mutations, it'll be more in terms of the symptoms that it causes and things like that. But I don't know. I haven't heard of that, but I might have missed it.
Okay, thank you. And last question for the day. If someone had cold symptoms, how long would they have to stay home?
They would need to self-isolate for, so the quick, easy answer is 14 days. But there is a nuanced answer that is for a minimum of, I believe it's a minimum of 7 days after the onset of symptoms and 3 days after the last time they had a fever but didn't take anything like Tylenol. And the reason there's these two answers is the easy answer is the community spread containment answer. We just tell everyone 14 days. The other answer is if you're really trying to get them back into school, or you're really trying to get them back into the hospital as a healthcare worker. So we can cut the time down if it's a healthcare worker, because we can't have a situation where we don't have enough nurses. So there is this nuanced answer that the CDC has. So you might apply that, for example, to a teacher, if the teacher really needs to be back in school. And then people invariably ask, well, should we do a test? Should we do a PCR test to see if they still have it before they go back to school or before they come back to work? Interestingly, the CDC says only if they were symptomatic. And we can talk about why if you want, but the CDC does not require a test for somebody who was COVID positive. Now we're not talking about exposed. We're talking about somebody who actually had a test for some reason and were COVID positive, never had symptoms, want to go back to work. Do you retest them? The recommendation is no. You wait 14 days, they go back to work.
Okay.
And then, of course, people invariably say, well, yeah, but I read something about how somebody can keep going without clearing the virus and stuff. And okay, there are some case reports. It's true. A few.
And Dr. Miller, I missed a question. One question in the chat that I missed was, do you expect the numbers to rise in the colder months?
Yes. So right now, as you probably know, we're still in our first wave. We have definitely truncated or flattened that wave, and that has been tremendously beneficial for the healthcare industry. We are so appreciative because we were going to be completely overwhelmed here. The initial projections were that we were going to have 80 patients in mid-June in our hospital. We have a 25-bed hospital. And it was going to be that because there was going to be such a massive outbreak like we saw in New York, and all of the other hospitals in the area would also be so overwhelmed that we wouldn't be able to transfer anybody out. And so it was because of sheltering in place that we were able to avoid that. Now, we can argue whether that model was correct, and maybe it wouldn't have been 80, maybe it would have only been 40. But having 40 COVID positive, very sick people in our hospital, plus our usual patients, would have been overwhelming. We would not have been able to handle that. And in those situations, we do what's called triaging, where people who are not expected to survive are made comfortable and not given treatment. It may be surprising for people to hear that, but that's what a disaster means. That's what disaster training is. In hospitals, we as doctors are trained to do that kind of triaging if we have a disaster where our system is overwhelmed and we can't take care of everybody. And we were prepared to do that in June if it had come to that. Shelter in place helped us prevent that, so we did not have that. We still have not had a single patient with COVID admitted to our hospital yet. Now, to get back to your question, so we're still riding out the first wave because we, instead of allowing it to do this, we've allowed it to do this. Great. So we're not going to be overwhelmed. Then are we going to see a second wave? Well, yes, I do believe we're going to see a second wave. It's probably going to start around October because that's when influenza normally starts. Now, paradoxically, we should have a very light influenza season. We should have a very light cold season because everybody's wearing masks, or most people are wearing masks, we're social distancing, we're washing our hands, and those things, of course, reduce the transmission of influenza and the cold. So we actually may have a pretty healthy season if you think about it, but I do think that that is when we should see another rise. And then probably what will happen is it'll all kind of fade out, say by March or April of next year, and then make another reappearance maybe around October of 2021, and then maybe we'll be done with it. And hopefully that's the situation. And that is based, my statement is based on kind of the pattern we saw both with SARS-1 and with the 1918 influenza.
Dr. Miller, thank you so much for your time. You've been incredibly informative. You've given us wonderful information. We appreciate you giving up 2 hours of your day for us. I want to remind folks at FBUSD that Dr. Miller has agreed to return to our schools to answer questions, 30 minutes each per site. Alt Ed will probably be going with the middle school. And then Dr. Miller has also agreed to be present at our school board meeting on July 30th for questions for the board as we look to approve our reopening plans. All that is up and coming. So Dr. Miller, again, thank you for your time. Those of you who still have more questions, I will create another doc so that we can start collecting those questions and then have those ready for Dr. Miller upon his return. Again, thank you all for joining us. We will have this recording available off the FBUSD blog and off our website as soon as it's ready. Thank you again, Dr. Miller. Everyone have a great day.